Hello everyone, welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki, one among the guys behind Noble Psychiatry and Noble Pathway. I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we encounter individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that affect not only their mental health, but their families, relationships, and the quality of life. That is why this conversation is important. Today, we'll explore a topic on anxiety disorders, an overview and a clinical approach produced and designed by Noble Psychiatric Services in a practical, evidence-based, and clinical relevant way aimed at improving patient care and strengthening our approach in mental health in general. So thank you for being here, and we will jump into the conversation. By the end of this session, you should be able to differentiate between normal adaptive in anxiety, the diagnostic framework founded on the DSM dedicated to general anxiety disorders, panic disorders, and social anxiety disorders will also be clear to you. The pharmacological and psychotherapeutic treatment will be discussed regarding first-line intervention. We will also comment on how anxiety can manifest itself in special people, including comorbidities conditions such as depression and substance use disorders. Such goals conform to the contemporary clinical competencies which are advocated by the American Psychiatric Association. Anxiety is a form of emotion as a response to perceived threat to ready the body to either fight or flee. This becomes excessive, persistent, and disproportional, resulting in functional impairment and causing pathological anxiety. Anxiety disorders are commonest mental health disorders in the world, affecting about 301 million individuals, and this is indicated in 2024 by an article Pretela et al. 2025. Anxiety has clinical expression in both primary and psychiatric care in form of somatic complaints such as palpitation or dizziness. It can be observed that the spectrum of anxiety allows clinicians to distinguish between contemporary stress response and chronic condition. Anxiety screening should be considered essential in psychiatric screening because it is a higher level of comorbidities with depression and drug use. Neurobiologically, anxiety indicates a loss of regulation at the limbic system, especially the amygdala, hyperactivations, and the lack of the prefrontal cortical inhibition. The depletion of the serotonin and the GABA boost neuronal excitability, where an overrelease of norepinephrine by the locus coeruleus is the cause of the autonomic symptoms such as tachycardia. Persistent activation of the HPA axis is also common with chronic anxiety leading to elevated cortisol levels, which reinforce stress responses. The studies of also using functional MRI show effective therapy, particularly using serotonin selective receptor inhibitors, which is SSRIs, or cognitive behavioral therapy, CBT. It does equalize the amygdala prefrontal connection, and this knowledge of these pathways informs the basis of the pharmacological and the psychotherapeutical rationale. As we look at the different types and classification of anxiety disorders based on the DSM-5, general anxiety disorder can be characterized by constant worrying, panic disorders characterized by panic attacks, both that are frequent and unpredictable. Social anxiety disorder is characterized by fear of evaluation by colleagues, and then specialized phobia are characterized by overwhelming fear of certain objects or situations. Agoraphobia involves the expression of fear towards circumstances in which escape may not be optional, as well on a different perspective. Separational anxiety and selective mutism are usually observed in children but may be prolonged in adults. The knowledge of this different differentiation can help specific treatments and prevent misdiagnosis. VAD is characterized by worry that is overwhelming and unable to be controlled on three parts of life. Patients may have physical manifestation, tension, sleepiness, or somatic pain. It needs to be at least 6 months and overly distressing and disabling. About 6% of lifetime prevalence of GAD is purely clinical. The illness is normally chronic though varying among stresses. It is essential to differentiate general anxiety disorders and just normal worry, as well as anxiety-related medical condition. Their intervention entails CBT and SSRIs, and their effectiveness has been well supported. Panic disorders is an abrupt, intense fear that is associated with somatic symptoms such as shortness of breath, chest pain, and feeling of dizziness. These attacks are their greatest within few minutes, and they are usually accompanied by constant concern of the future attacks. Some of the avoidance behaviors that develop in patients may lead to agoraphobia. Diagnosis should be differentiated because panic attacks can mimic as medical conditions, supraventricular tachycardia, asthma, hypothyroidism, so should be excluded with the help of relevant studies. These treatments involve CBT, pharmacotherapy such as SSRIs and SNRIs. Benzodiazepine should be used sparingly because there is a risk for long-term dependency. Social and specific phobias is social anxiety is characterized with experiencing fear of negative assessment in social or performance contexts. Specific phobias, this consists of extreme anxiety over certain stimuli, for example, animals, flying, or heights. These two cases of severe functional impairment, which in most cases lead to avoidance, which increases anxiety. The initiation is usually early, and hence early intervention is very important. CBT, as far as exposure based, is a first line treatment aiming to desensitize the patient to the stimuli they do not want to see. Pharmacologically, we can use SSRIs or beta blockers like propranolol in case of performance anxiety can also be added. Recent evidence indicates that exposure therapy has been found to be very effective when it comes to this type of anxiety. Comorbidities, depressive and PTSD disorders and substance use are common with anxiety disorders. These comorbidities make it difficult to diagnose and manage in that the symptoms tend to be overlapping. Psychological factors such as hypothyroidism, heart irregularities, or pulmonary diseases can need to be taken into account, especially in newer cases. Some other things that we need to take into context is some drugs, e.g. steroids, corticosteroids, caffeine, and decongestants can also cause the developmental of a feeling of anxiety. A complete history and physical examination is very important to prevent misdiagnosis. Combining therapy of different comorbidities with anxiety provide a better result. As far as the assessment and the workup, anxiety must be assessed as part of a psychiatric interviewing that involves onset date, the frequency, and the impact of the anxiety on the normal functioning of the day-to-day. Clinician should attempt to find potential presiding and differentiating variables of anxiety and mood disorders. The objective symptoms measured is regarded to be a significant method. For example, using technologies such as General Anxiety Disorder Scale number 7 and Hamilton Anxiety Rating Scale may be beneficial to monitor the treatment effect. In order to de-isolate physical causes of same symptoms, standard medical testing, lab works, thyroid function, heart analysis can also be conducted. Comorbidities related to depression, PTSD, and substance use is first tested to assist in giving a positive mental image of the patient. The interdisciplinary team, a supportive attitude during assessment encourages a simulation of trust in the patient, and that increases the number of symptoms that are definitely reported. When we move into the treatment overview, the pharmacological management of anxiety disorder is expected to correct the neurotransmitter imbalance and decrease the hyperarousal. The first line is SSRIs and SNRIs because they are safe, effective, and tolerable in various types of anxiety. Their effect is normally reached between 4 to 6 weeks, and that's one thing that we always have to educate the patient. Buspirone, it can be applied to generalized anxiety disorder, but it cannot, most of the time, not be usable for panic disorder. Hydroxyzine is also an option to provide short-term medication for mildly anxious patients who do not take benzodiazepine. As we have talked about, benzodiazepine are for short-term and acute anxiety because they can cause some sort of tolerance and dependency, and they should be considered only temporarily and used sparingly. We have to educate the patient about delayed work of the antidepressant between the 4 to 6 weeks, as I had mentioned before, so that their adherence is much more improved on that. As we move on to a psychotherapeutical, CBT is a most evidence-based psychotherapy of anxiety. It assists patients to label and reconstruct negative cognition and contribute to anxiety, and the behavioral exposure therapies lessen avoidance and desensitize fear reflexes. It comes in handy during exposure therapy, especially in specific phobias and panic disorders, because anxiety sensitivity is reduced through gradual exposure. Mindfulness and acceptance-based therapies have not been left, as they are distinguished themselves by yielding good results and assisting the patient to abide and part with anxious thoughts without any blame. A treatment, both biological and cognitive aspect of anxiety, whether it's medication or psychotherapy, often works best and addresses the need of the patient. Lifestyle changes need to also be promoted, especially regular exercises, adequate sleep, as well as decreased caffeine and alcohol intake that also can contribute to different levels of anxiety. It should be noted that individualized care is holistic and enhances compliance and definitely do lead to some sort of improvement. As we look at the spatial different population, when we look at presentation of anxiety can differ greatly when we think about different populations. The first population is anxiety in children, comes as far as physical, like headaches or stomach aches, and could end up causing school, missing, it could end up cause missing attendance in school. It is important to identify them early to avoid them being long-term psychological. In the elderly, it may appear similar as cognitive impairment and can be mistaken as depression or dementia. And in case of medical ill patients, anxiety can also tend to be chronic conditions, illnesses such as diabetes and heart conditions or heart diseases, difficulty to manage, thus deteriorating appearance and outcome. Following treatments or failure with the first-line therapies, clinicians may resort to medication supplements such as buspirone, as we've talked about. We can augment also with atypical antidepressants and also increase sessions in psychotherapy. The developmental, medical, and psychosocial context takes into consideration the patient-centered approach that delivers superior recovery path. So as we talk about the key takeaways, in summary, anxiety disorder entails one of the largest health issues in the population in the US, though they are very responsive to evidence-based when they are identified at an early age. Clinicians will never want to be limited when assessing someone to provide a comprehensive view involved both psychological and in the physical aspect. The first line SNRIs, SSRIs, CBT are the fundamental part of the treatment, and they have to be considered considerable clinically. Activities like normalizing discussion with anxiety with patients, removing stigmas, are also some of the other things that can also be approached. And that concludes our session. We appreciate you taking time to listen. If you do have a question, for those ones that are attending the sessions in person or attending the sessions by listening to this video, if you have a question, feel free to drop a comment or drop a question, and I will be glad to follow up with an answer. With that, from Noble Psychiatric Services, we check out. Thanks again for listening. Bye-bye.